All right, the adrenal glands are sitting on top of each kidney. So we have a left and right adrenal gland. What are the three hormones produced by the adrenal glands? So they are the salt, sugar, and sex hormones in the female. In the male, there are only two hormones, which are the salt and sugar hormones. The salt hormone is aldosterone, and the sugar hormone is, of course, cortisol, right? Okay. So there are two parts of the adrenal gland. We have the medulla and we have the cortex. So the medulla part, which is the inner part of the adrenal gland, is where your epinephrine and norepinephrine is made. The outer, the cortex, again, is the salt and sugar hormones. Okay, and then the sex hormones are also there in the female. In the male, of course, where is the sex hormone? In the testicles. Okay. Okay, so just review medulla and cortex. Okay, I already gave you a shortcut. So the glucocorticoid, which is cortisol, is responsible for the blood sugar, right? So it's a steroid, it's a glucocorticoid. So you need this during periods of stress. That's why it's called the stress hormone or the sugar hormone. Helps you during stress so you can have adequate sugar to support the stressful event. And then you also have the mineralocorticoid, which is aldosterone. Aldosterone helps you how? How, Brianna? You're the only one that's searching the transportation. What does aldosterone do? Okay, get off the MTA app. There's nothing you can do. Okay. We can't control the weather. But you will get home eventually. Okay, so what does aldosterone do? How? Sodium and water retention. Okay, so are we good? Yes, sex hormones are important, but are they life-threatening if you have too much or too little sex hormones? Is that a problem? Not really life-threatening, right? It's a problem, but it's not life-threatening. However, if you have a deficiency or an excess of the cortisol and aldosterone, is that life-threatening? Yes, very. So let's focus on those two. First problem is pheochromocytoma. So what is this? This is a rare tumor growing on the medulla. What is produced again in the medulla? Epinephrine and norepinephrine. So if you have a tumor growing in your adrenal medulla that produces catecholamines, what will this patient look like? What would be this patient's problem? So they will have high levels of what? Epinephrine and norepinephrine. Yeah, again, where is the tumor? Growing in the medulla. So the tumor will be therefore producing large amounts of epinephrine and norepinephrine. So knowing that, what will this patient look like? A chicken. Okay, so very nervous, very hypertensive, okay, high heart rate, sweating all the time, okay, short attention span, etc. But what will kill this patient is the severe hypertension that results. So this patient's blood pressure will be over 200, etc. Who can get it? Anybody. But it peaks between 40 and 50 years of age. Men more than women. So let's go straight to what will they look like? All signs of severe hypertension. So severely hypertensive patients have a headache, they're sweating, and they have palpitations. Can they have a stroke?
Yes.
Can they die? Yes. Physically, the signs would be the tumor is quite big. Phagochromocytomas are large tumors. So when you palpate the abdomen, can you feel the tumor? Yes. What you do not do is palpate or squeeze the tumor. Do not palpate it deeply. Do not squeeze the tumor because this will cause a sudden release of epinephrine. And what will happen to the patient? Patient will die right there, okay, like a chicken. So here, blood pressures can reach or exceed 250 over 150. That's enough to pop blood vessels in your brain and cause hemorrhagic stroke. Could also have arrhythmias, aneurysms, or of course, kidney injury, kidney failure. How do we know? Well, we need to look at the manifestations and of course draw blood levels of epinephrine, your catecholamines, and then do a CAT scan or MRI to locate the tumor, confirm the presence of the tumor. So if it's a tumor, how do we treat it? Remove it. Okay, that's the main cure for phagochromocytoma. However, until you get surgery, what do we do? What's the main problem? Hypertension. So what will the patient receive? Dozens of antihypertensives. So name all the antihypertensives that you know, beta blockers, ACE inhibitors, ARBs, diuretics, etc. That's what we will be giving the patient, okay? Vasodilators, nitroglycerin, calcium channel blockers, all right? But what's the only treatment? Surgery. We have to remove the tumor. In the event that the tumor removal includes removal of the adrenal gland, well, the problem will be how many tumors do we have? If the patient only has one tumor, then therefore, do they lose both adrenal glands? No, only one. Remember, what do the adrenal glands produce? Aldosterone. Yeah, there's cortex also. Yeah, so we have the medulla and the cortex. Medulla produces epinephrine, norepinephrine. What about the cortex? Produces aldosterone and cortisol. Okay. So if you only lose one, you will probably require hormone replacement for a few months. Okay, because the remaining gland will need time to compensate, right? Because now you're down to one gland. So the remaining gland may need time to make up for the loss of the other one. So you'll require a temporary or short-term hormone replacement. Okay, you'll be given hydrocortisone, okay, supplements. Temporary until your hormone levels level out. Cortisol. Yeah. So we'll draw labs to see what your cortisol and mineralocorticoid levels are. If they're back to normal, then we can stop the hormone replacement. Until then, you'll be on hormone replacement. Okay. If you lose both, though, how long will be the hormone replacement for life? Any questions? That's it. That's it for phagochromocytoma. It's pretty simple. Next, no, exam 2. All right, here's the next problem. Addison's disease. This is a deficiency of adrenal hormones. There are two causes here. We have primary. Primary is a dysfunction of the hypothalamus and pituitary gland, meaning the problem is with the pituitary gland. Why? Why does it affect the adrenal gland? What is the role of the pituitary gland? It is the master gland, correct? Okay, so it controls all other endocrine glands. So this problem is usually caused by a tumor. So if we have primary primary adrenal insufficiency, also called Addison's disease, the problem is usually caused by a pituitary or hypothalamic tumor. You have a tumor in your pituitary gland or the hypothalamus. We have secondary adrenal insufficiency, which is caused by sudden cessation of hormone replacement therapy. Who are taking hormones for a long time? No, steroids, sorry. Who are taking steroids for a long time?
Cancer patients.
No.
Usually ask.
Okay, asthma or any autoimmune disorders, right?
Yeah.
So Crohn's disease, rheumatoid arthritis, lupus patients, right? Okay, so those are people or patients who receive organ transplants. So those are people who have to take steroids in order to live. What did you learn in pharmacology? When they have to stop the steroids, how do they stop it? Taper. What does this say? Is this a tapered cessation or a sudden cessation? This is sudden cessation of adrenocortical topical therapy. So sudden cessation of hormones, steroid therapy. So that's secondary. We don't call it Addison's. What is Addison's again? Addison's is the primary adrenal insufficiency. Where's the problem again? The pituitary gland or the hypothalamus has a tumor affecting the adrenal glands. Because remember, again, the pituitary glands control the pituitary gland controls the adrenal glands. Okay. What's the secondary again called? Caused by sudden cessation of steroid therapy. Okay. Have you ever been told why we don't allow patients to stop the steroids suddenly? What was the rationale given to you? Or did you just say, okay? So therefore, what will result? This one. All right, so here's the reason. Okay. In severe cases, this can actually lead to death. We will discuss adrenal crisis or acute adrenal insufficiency. Addison's disease is not acute. Are we clear? Yeah, so you won't die from Addison's disease. So you will die from acute adrenal insufficiency, also called adrenal crisis, which can occur in Addison's disease. Are we clear? All right. But if you have Addison's disease and you're complying with the hormone replacement, you'll be fine. Are we clear? But the complication of Addison's disease, which is a severe form of adrenal insufficiency caused by sudden cessation of exogenous hormone therapy, is called adrenal crisis or acute adrenal insufficiency. That is life-threatening. We'll get to that shortly. So how do we treat Addison's disease again? You don't have the salt and sugar hormone, so what do? You don't have enough, so we give it to you. Okay, we replace it. We give you the hormones every day for life. What do you want, 2 weeks? What will we do the rest of your life then? You only need the hormones for 2 weeks? So before we go to Addisonian crisis or adrenal crisis or acute adrenal insufficiency, there's different names. Let's look at the manifestations. So Addison's disease is you have too much or not enough salt and sugar hormones. Not enough. So what do those two hormones do again? So cortisol is responsible for raising your sugar, correct? And aldosterone is responsible for your salt, so your sodium levels and your volume levels. Okay, so maintain blood pressure, blah, blah, blah. So if you're short on cortisol, what happens to your blood sugar? Low. What happens to your sodium level? Low. What happens to your blood pressure? Low.
Drops.
What happens to your potassium level? High.
Increases.
All right. Okay. So let's go to Addisonian crisis. So this is now the life-threatening part. So causes again is, let's say, you have Addison's disease. Okay, let's start with that scenario. You're taking the hormones, correct? And then you suddenly stopped. What could be a reason why you stopped? Could be you couldn't afford it. What else? But these are not really expensive. Hormones are not expensive. They're okay. Or you got sick, right? That's because if you're taking hormones, what happens to if you're taking steroids for a long time? Okay, so can these people get sick? Yes. So can that happen if you have Addison's disease? Yes, because you're taking these steroids every day for life. So can these patients get sick? Can they get sick enough to not be able to take the hormones?
Yes.
Yes. Okay. So can they go into this crisis? Yes. What happens in the crisis is, imagine severely low hypoglycemia, severely high hyperkalemia, severely low hyponatremia. Are those life-threatening?
Yes.
Can each one kill a person independently?
Yes.
So how do you manage it? Can you prioritize one over the other?
All of them.
So is this a critical patient? Yes. So is Addisonian crisis serious? Yes. How is it triggered again? How could Addison's patient or any patient taking hormones develop Addisonian crisis? They stop taking the hormones or they got sick. When we say sick, does it have to be a physical illness? No, it could be psychological, it could be emotional, right? So let's say I asked Brianna out, said, Brianna, will you go out with me? And she said, hell no. And then on top of that, she said a few other things. Like, look at you. She could have just said no, but then she had to say extra stuff. So how does that affect me? And I happen to be with Addison's disease. Okay, I'm taking hormones. And then, so what happened to my stress level? So is it different from me undergoing surgery, becoming septic? Is it any different? Same. So same stress level, right? So same stress imposed as if I underwent surgery, or I got sick physically, or this time I got sick emotionally and psychologically. So is the hormones I was taking enough for that stress level? Yes or no? Was it enough? Enough. Is it still enough for my needs? No more. So can this occur?
Yes.
Yes. So let's go to treatment. So if I have acute adrenal crisis, so if it's Addison's disease, what do we do again? What's the only thing we do? Give them the hormones, okay? And then monitor blood pressure, blood sugar, etc. So this management here is referring to the crisis, which is the life-threatening form. All right, so what do we do? What were the problems again in crisis? Hypotension or hypertension? Hypotension. Hypoglycemia or hyperglycemia? Hypoglycemia. Hyperkalemia or hypokalemia? Hyperkalemia. So what do we do for each one? Let's start with the blood pressure first. So what do we treat the low blood pressure first? This patient is in shock. So what do we give? Fluids. What would be the best fluids for this patient? Isotonic, hypo, or hypertonic? Iso. So given three, we have three isotonic solutions: saline, lactated ringers, or D5W. What would be better for this patient between the three? Why D5W? Very good choice, because you're not only giving an isotonic solution which will increase blood pressure, you're also giving sugar at the same time, because we need to give the patient glucose. Okay. So that takes care of the blood pressure. How else can we handle blood pressure? We will also give the hormone, hydrocortisone. So hydrocortisone IV will increase blood pressure at the same time. The benefit of hydrocortisone is it has both glucocorticoid as well as mineralocorticoid benefits at high doses. So let's say you give this patient 50 to 100 milligrams of hydrocortisone. That will not only raise blood pressure, but also raise blood sugar at the same time. All right. And then how did we treat hyperkalemia again? We did this last semester. SPS. Yeah. Okay. Sodium polystyrene salt. Is that your first choice though? Is the potassium here is 6.87 or higher? So what would be the faster way to drop potassium? You have several options. One, calcium gluconate. Can we give albuterol? Yeah. Yes. Do we give regular insulin with dextrose IV? Do we give yeah, you said SPS, right? So yeah, can we give those? Okay, so we have several options to drop potassium.
Thank you, Mr. How much longer you have in there?
About 20 minutes.
Because we're obviously saying we should shut it down. It's getting worse out there. A lot of trains have been shut down, so I don't know how people are gonna get home.
Okay, we're wrapping up.
Huh?
We're wrapping up.
Okay.
So given the three problems, is this patient conscious? Hypoglycemia, hyperkalemia, hypotension, probably unconscious already, right? Okay. So feeding, how is it gonna happen now? Is this patient intubated maybe? Yes, intubated on a mechanical ventilator. Any question about the crisis? Okay, so let's go to the everyday management. So this will be with the teaching now. So how do we teach these patients to handle their disease at home? Okay, so here we are. The hormone replacement. Now it's important to teach them about the hormone replacement and what to do. Here they have to understand that they're taking the hormones for life because they don't have it. Their adrenal glands can't produce it. What happens to their need or hormone dose requirements during times of stress? Let's say it's exam week, it's, you're getting married, getting divorced, you're sick in the hospital, you're undergoing surgery. So what happens to your hormone requirements? Increases. So do we need to increase the dose? Okay. Can they do that on themselves? So you have to call the physician, right? Ask the physician, okay, I'm undergoing, I'm pregnant, okay, or whatever. I lost the baby, okay? So whatever stress the patient's undergoing, they tell their provider, and then they'll adjust the doses. Okay, what to do when they get sick? So let's say they're sick enough that they cannot take the hormone replacements by mouth anymore. What should they do? Very good. So either go to the hospital, or if someone can administer here, there's a kit wherein they can give it IM. All right. So emergency. So let's say they're symptomatic, getting unconscious, and then they need the hormones. They can't take the pill. So someone can give the hormone IM. All right. They have a kit at home. But if none, then they'll be taken to the hospital. All right. Okay, I'll let you go.